Hello, my name is Louis. I graduated as a medical doctor 1.5 years ago, and almost exactly 1 year ago I've gotten diagnosed with Myasthenia Gravis myself, hence my interest in the subject. So in this video we'll have a look at this relatively new drug named Vyvgart, produced by the Belgian biotech company Argenx. It has been approved by the FDA for the treatment of generalized myasthenia gravis in December of 2021, as well as more recently in the EU since August of 2022. First we'll have a look at what kind of drug it is and its mechanism of action. Then we'll have a closer look at the study they conducted so we can answer some questions like what kind of results can we expect, who is it for, how do you take it, what are the side effects, and more. Efgartigimod, trade name Vyvgart, is essentially just a fragment of an antibody. You might be familiar with other drugs like those funky ones ending on mop, like rituximab or infliximab, as these are well-known monoclonal antibodies. These drugs can bind to a target molecule and flag them, so the patient's own immune system can come in and destroy these flagged targets. Efgartigimod, however, is just a fragment of an antibody, and therefore cannot activate the immune system to clean up unwanted molecules from the body. To understand what it can do, we must first dive a bit deeper into the functioning of the human body. Our body is an amazing biological machine optimized during many years of evolution. It's not perfect, or we wouldn't be talking about medication, but it's amazing nonetheless. It's no surprise many of its processes have evolved to be more efficient overall. One example is the fact that our body is capable of recycling antibodies. This ensures they don't have to be produced completely from scratch again, wasting resources and energy. Amazing, right? Unless some of those recycled antibodies are responsible for making you sick. Not all antibody types are capable of being recycled, but the IgG subclass is, which is also the class that the antibodies responsible for myasthenia gravis almost always belong to. Due to the recycling mechanism I will explain in a moment, the lifespan of IgG antibodies is extended up to 4 times, which subsequently also causes an increase in concentration of these antibodies. Normally this would be exactly what you want, since more IgGs means a longer lasting and stronger resistance to intruding pathogens. In the case of an autoimmune disorder like myasthenia gravis, however, not so much, since some of these IgG antibodies are faulty and actually aid the immunological destruction of normal functioning tissues. In the case of MG, it's the connection between nerves and muscles that is destroyed, resulting in the typical muscle weakness. Thus, in these patients it would make sense to try and eliminate these faulty IgG antibodies from the blood. We can already do this via plasma exchange, where we remove a patient's plasma together with all their antibodies and more, during multiple sessions of needles and tubes. While this procedure is usually, not always, a fast and efficient way to reduce a patient's symptoms, it is cumbersome, requires specialized centra, removes not just IgG but all antibody types as well as other things like coagulation factors. In short, it's not ideal. Efgartigimod can be seen as a more specialized way to reduce only circulating IgG antibodies while leaving all the other antibody classes intact. It does so by interfering with the normal recycling process of IgG antibodies. Here's how it works. This is a blood vessel transporting blood, which also contains circulating antibodies. Let's zoom in a bit on where the cells lining the blood vessel, also called endothelial cells, make contact with the blood. The normal recycling pathway starts when at random, IgG antibodies are taken up into the endothelial cells. Here they are contained inside a vesicle. The walls of these vesicles are lined on the inside with a receptor called the neonatal Fc receptor. This neonatal Fc receptor has an opening which allows the binding of only a molecule that's completely complementary with the shape of the receptor. Turns out that the structure that is complementary with this Fc receptor is the tail of IgG antibodies, and it's this binding of an IgG antibody to an Fc receptor that saves it from destruction, as the vesicle merges again with the wall of the endothelial cell it releases all bound IgGs back into the bloodstream. All free IgGs that were not bound to an Fc receptor are less fortunate and get destroyed. Now remember when I said in the beginning of this video that Efgartigimod or Vyvgart was essentially just part of an antibody? Well, it's structurally exactly the same as the tail of an IgG antibody, only modified to have an even greater affinity for the Fc receptor. So when a person is taking Efgartigimod, it will also be taken up into the endothelial cells. Here it will, just like the IgG antibodies, fit into these neonatal Fc receptors. This competition for a spot on an Fc receptor will ultimately lead to more unbound IgGs that won't be recycled but rather destroyed. The end result is a reduction in circulating concentration of all IgG antibodies. Among these, as said before, are also faulty autoantibodies responsible for Myasthenia Gravis. So, as the concentration of these pathological IgGs drops, we can also expect a decline in symptomatology as there are less of these antibodies initiating the immunological destruction of the connection between nerve and muscle. Now that we know how exactly Efgartigimod works, let's analyze its phase 3 study. First, let's have a look at the kind of patients that were included in the study. Any observed results will only be applicable to this specific population. So in the ADAPT phase 3 study, they gathered 167 participants, aged above 18 and suffering from the generalized form of Myasthenia Gravis. All patients were at least on one stable medication for their MG, yet continued to have high MG-ADL scores, which is a questionnaire regarding activities of daily life. These high MG-ADL scores, despite ongoing treatment, suggest we're dealing with an MG population that is refractory to standard treatments. Most of the patients, 129 to be exact, were positive for the most common autoantibody found in MG, the one against the acetylcholine receptor. Next, they randomly divided these 167 participants into two groups. One group would receive a treatment cycle consisting of one infusion of Efgartigimod a week for 4 consecutive weeks. The other group would get similar infusions only with a placebo. After this first treatment cycle of 4 weeks, almost all patients in both groups underwent a second cycle. In the end, both groups were compared using questionnaires that evaluated their functioning in daily life, as well as more quantitative scoring systems assessed by a physician. I have pooled all the main findings of this comparison into the following table. Let's go over it together. Starting off in the first row, the primary outcome they looked at was the number of patients with antibodies against the acetylcholine receptor that had a reduction of 2 or more points in their MG-ADL scores that lasted for more than 4 weeks. Let's quickly pull up the MG-ADL score so we can see what these 2 points actually look like. So the patient is asked to score some of the most common symptoms in myasthenia from 0 to 3, with 0 being asymptomatic and 3 being severely affected. A 2-point reduction can mean an improvement in any combination of these symptoms. Feel free to pause the video and see what that could look like. In the group receiving placebo, 30% of the participants showed such an improvement of 2 points or more. However, this can be explained by the very fluctuating nature of the disease. Patients can experience a variable degree of muscle weakness during a single day, so very short term, as well as long term, over multiple weeks or months. So these 30% of patients in the placebo group that showed improvement are just proof of the naturally fluctuating expression of Myasthenia Gravis. In the Efgartigimod group, there was 68% of the participants that showed such an improvement. We can assume a similar percentage of these patients have improved solely due to the natural fluctuations in the disease as seen in the placebo group. Yet, that leaves about 1/3 of this group that improved 2 or more points thanks to Efgartigimod. A final third of the patients in this group didn't improve or even deteriorate despite Efgartigimod, confirming not only the variable clinical expression of MG but also the variable response towards drugs. The first row of this table taught us that a large portion of MG patients receiving Efgartigimod experienced an improvement in symptoms. But it's not just that these patients felt better, they were objectively better, as shown by the similar results obtained by a more quantitative testing method, where a physician assesses the patient's muscular strength by doing many tests, like for example the number of seconds a patient can hold up their arms or the number of seconds it takes for an eyelid to start drooping. One thing to note here is that while in the Efgartigimod group the number of people feeling stronger and objectively being stronger was almost exactly the same, in the placebo group less people were actually objectively as strong as they felt. The study lacks power to draw any definite conclusions out of this, but it does suggest that those MG-ADL scores in the placebo group might have been inflated. Patients might feel better when getting possible infusions of this new drug without having any measurable improvement in strength. If that's the case, then the effect of Efgartigimod compared to not taking Efgartigimod is even larger than those MG-ADL percentages might suggest. Next up was the total number of patients who ended up dropping down to a 0 or a 1 in their total MG-ADL scores, which means no or very minimal residual symptoms. In the Efgartigimod, 40% reached this state, which is impressive considering all participants had to have at least a score of 5 at the start of the study to be eligible, while the average MG-ADL score was around 9. Interestingly, this study failed to show any effect of Efgartigimod for the patients that were seronegative, meaning they have no antibodies against the acetylcholine receptor. Strictly speaking, seronegative would mean there haven't been found any antibodies known to be directly responsible for causing myasthenia gravis in the patient's blood. This used to be only antibodies against the acetylcholine receptor, but at the moment there are 3 in total, since anti-MuSK as well as anti-LRP4 antibodies have been discovered. Now, in the 38 participants classified as seronegative by the authors, there were actually 6 that were MuSK antibody positive, so not really seronegative. Anyway, in this subgroup of MG patients with no antibodies against the acetylcholine receptor, there was 68% that improved under Efgartigimod, which at first glance seems good, right? Unfortunately, 63% in the placebo group improved as well, so we cannot say with certainty that it was Efgartigimod that caused the improvement. It might be equally effective in this subgroup of MG patients, and the placebo group might have just improved by the same amount by sheer chance, but we'll need another study with more participants and more power to prove so. For now, Efgartigimod cannot be recommended with conviction for these patients. The amount of patients experiencing any adverse events was similar in both groups. Most commonly seen was headache, nasopharyngitis, nausea, as well as diarrhea. Both groups also experienced similar infection rates, which is to be expected with any form of immunosuppression, and the lowering of IgGs by Efgartigimod is exactly that. The infection rate is even a little higher in the Efgartigimod group, because all these patients were effectively immunosuppressed, while in the placebo group some were taking only acetylcholine esterase inhibitors besides the placebo and thus experienced no immunosuppression. In short, Efgartigimod is not a wonder drug that evaporates all myasthenia symptoms from the face of this planet. It has, however, shown to be variable degrees of effective in at least a third of acetylcholine receptor antibody positive generalized myasthenia patients. For the other subtypes of MG, further research is needed. Due to its fast onset, it will probably be used as an alternative steroid-sparing option in those unable to tolerate first-line therapies with slower time till effect, or those refractory to other therapies. We now know how Efgartigimod works and the kind of results we can expect from it. However, you might still have some more practical questions regarding the drug. I've tried to read your mind what those questions are and I will answer them now.